Today I'm going to talk about celiac disease, that is a gluten-related disorder, and I'm going to talk about non-celiac gluten sensitivity in addition. Yes, I'm a professor of medicine at Columbia University and director of the Celiac Disease Center there that we formed over 20 years ago. So I've had a very intense academic and clinical interest in celiac disease for over 30 years. So this is the small intestine, and you can see that we really evolved to eat very little and absorb the nutrients from the food because it's redundant. We look down through the endoscope, we see the small intestine has got folds. Under the microscope, we have villi, as we can see here, and then we have, under the electron microscope, we have microvilli. So we have this enormous surface area. We have 22 feet of small intestine. We have this enormous surface area to absorb food. And the small intestine that you can see here is specialized to absorb certain nutrients in different areas. Now, the whole 22 feet will absorb fat, protein, and carbohydrate. So you can have a resection of half your small bowel and still maintain your normal weight. In the upper small intestine, the duodenum especially, fat-soluble vitamins, iron, zinc, and calcium are absorbed. Folate is absorbed in the upper small intestine, and vitamin B12 is absorbed in the ileum only. So if this gets resected, you become deficient in B12. So what are the gluten-related disorders? Well, we have celiac disease, and then the intensely pruritic skin disease of dermatitis herpetiformis is really celiac disease. Then we have wheat allergy, and as a gastroenterologist, we don't see wheat allergy all that much, but you'll hear about food allergies. And then we have people who avoid wheat or gluten, or PWAGs, and this includes people who buy gluten-free food for some reason, for people who self-identify as being gluten sensitive. And that's an area that's been expanding greatly. So here you can see that this is the genetic tree of the grasses. And you can see that wheat, rye, and barley that contain gluten are closely related genetically and are more distant genetically from oats, rice, corn, etc. And these are considered to be safe for people with celiac disease. And this is a grain of wheat, and this is a very nutritious grain, probably the most nutritious grain. And it consists of the endosperm, which is the part that's got most of the carbohydrates, protein, but it doesn't have minerals and vitamins. We have the germ, which is very rich nutritionally, as is the bran. But during the milling process, the bran and the germ get discarded, and we're left with the endosperm, which becomes the main part of wheat flour. And this is not nutritious. It provides a lot of carbohydrate, and wheat and rice are the main forms of carbohydrate around the world, as we know. And so it was, I think it was after the Second World War when the World Health Organization said that countries had to fortify wheat flour. So they make wheat flour healthy by adding back vitamins. Vitamins and minerals. Whereas other gluten-free flours, such as rice flour, does not have a high folate level or B vitamins or iron because it's not fortified. So what's celiac disease? So celiac disease is common, and it's one of the most common genetically determined disorders in the world. It affects males and females equally, but females get diagnosed more often than men because men don't go to the doctor like women do. It occurs at all ages, providing that you're eating wheat. It is based on immune reaction to gluten, and there are these autoantibodies that we measure, and that indicates that celiac disease is an autoimmune condition, but it's a unique autoimmune condition because it's the one that we know the environmental precipitant. We don't know what the environmental precipitant is for rheumatoid arthritis, multiple sclerosis, or type 1 diabetes. And what's unique about celiac disease is when you withdraw gluten, the patients improve. Something that's very interesting that I learned recently in some of these big European studies in which they identify people at risk, you can identify children based upon their phospholipid blood results who are going to get celiac disease before they start ingesting gluten. So there's a lot that we don't know. Now, celiac disease is estimated to occur in about 1% of the population. Now, in Colorado, in Denver based, there's this DAISY study, which is a diabetes autoimmunity study in the young. And in this, they've identified children at birth that have the specific HLA that allows them to have certain autoimmune conditions, but also celiac disease. And so they've been studying these kids for quite a few years, and the estimated cumulative incidence of celiac disease in Denver at age 15 is 3%. That's totally astounding. Now, to diagnose celiac disease, we like to have consistent pathology in endoscopic biopsies and a response to gluten removal. Now we have available these blood tests that are very highly sensitive and specific, and you've got to really have these genes, these HLA-DQ2 or DQ8 genes. This is a picture of someone with celiac disease, and you can see there's macroscopic atrophy. The small intestine, the duodenum, doesn't have all these circular folds, and this looks like colon. There are none of these finger-like villi. Now, how common is celiac disease and what's been happening? So this is a study done by Joe Murray from the Mayo Clinic, in which he measured these antibodies, the tissue transglutaminase and endomysial antibody. So if someone has TTG and EMA, they more than likely have celiac disease. That intestinal biopsy is going to be positive, and that has been used as a substitute for diagnosis. So he took serum that was drawn over 50 years ago. So this is this Warren Air Force Base cohort, which is a bunch of basically 20-year-old white men that were going into the Korean War. And the serum has been stored. And then he compared the results with 70-year-old white men and 20-year-old white men in Minnesota. And you can see 0.2% of these guys back then had positive TTG and EMA. So the prevalence of celiac disease back then was 0.2%, whereas it's close to 1% now. So there's been this 4 to 5-fold increase in celiac disease in this 50 years. And it actually occurred mainly in the 1980s and the 1990s for some reason. And we don't really know why that is. We can talk about the widespread use of antibiotics, etc. So, and how do we find out how common celiac disease actually is? Well, you're probably all familiar with NHANES, which is the National Health and Nutrition Examination Survey, in which they take about 5,000 average Americans and interview them, examine them, take bodily fluids, etc. And so for a period of time, they were asking the NHANES participants, do you have doctor-diagnosed celiac disease, or are you on a gluten-free diet? And then a representative sample was taken for those estimation of the TTG and endomysial antibodies. And it was recognized then that 0.7% of the population either had doctor-diagnosed celiac disease or positive antibodies. And this represented over 1% of white people. But of all those people, only 17% with celiac disease had been diagnosed. So we had this picture of all these people with celiac disease, of which only a few were on a gluten-free diet, and there had been all these people who were on a gluten-free diet, but only a few had celiac disease. And then He did further studies looking at NHANES over the next ensuing years, and over this period, 2009 to 2014, it appeared to be relatively stable. So there is evidence also from Finland that the big increase in celiac disease is now leveling off. And here you can see that these are the diagnosed with celiac disease in the orange box, and this is the undiagnosed. This is people with celiac disease who are not diagnosed. So now we say that about half the people with celiac disease in the United States are diagnosed. But this is in the setting of an overall increase in people being gluten-free. So here it's estimated that about 2% of the population were gluten-free, of which only this percent actually had celiac disease. So there was an increase overall in people with diagnosed with celiac disease, but this very great increase in people who are on a gluten-free diet. So why do you have celiac disease? Well, you've got to have these specific genes, and you've got to be eating gluten. 40% of us have these genes. We recently did some work with 23andMe, and it was 39% scattered all around the United States, had these either HLA-DQ2 or DQ8. And more than 90%, like 98% of us are eating gluten. However, only 1% get celiac disease. So it's therefore considered that these environmental factors are prominent. Now, what are some of the environmental factors? I thought you might ask that. So it was thought that breastfeeding was protective, getting celiac disease, as it is for much, but it's not. The timing of gluten introduction, there have been these big studies. For a while, we were advising people to give their children, if they were at risk, because maybe they were in a family of celiac people, to give a little bit of gluten between 4 and 7 months. But now we don't do that anymore because that has not been shown to be protective. It's thought that maybe the amount of gluten given in the 2nd or 3rd or 4th year of life might be important. But there are other factors. We know that being born by cesarean section increases the risk, having a GI infection, rotavirus, and it's been shown that where rotavirus immunization has been administered, there's less celiac disease. There's this universal virus that appears to be associated with celiac disease. And there was a study showing that the troops that went to Afghanistan and Iraq had an increased rate of celiac disease diagnosed if they had been diagnosed with Campylobacter gastroenteritis. Being born in the summer in the Northern Hemisphere increases the risk. And that's thought that the children are weaned and start to have gluten in the winter when they get their first infections, either upper respiratory tract infections or maybe gastroenteritis. Any antibiotic use. Women who take iron supplements in pregnancy have an increased risk of giving birth to a child who will later develop celiac disease. Any proton pump inhibitor use increases the risk of someone getting celiac disease. And we just did a big study in which we gave very high dose of omeprazole to people because we were looking at the microbiome. And actually one of the people, the volunteers, they seroconverted to positive TTG IgA. So a lot of these suggest that the microbiome may be important, but we don't have that answer at all currently. And it's not clear how someone, I recently saw a lady at age 88 who was just diagnosed with celiac disease, and she'd had previous duodenal biopsies showing she hadn't had it. So you can get it from any age if you're ingesting gluten. And so we didn't evolve to eat wheat, we evolved to eat meat. Because when we eat meat, our digestive enzymes chop up all the protein into single amino acids, dimers and trimers, which get absorbed very rapidly. But when we eat wheat, our endopeptidases can't chop it up into these single amino acids. Excuse me. And so we're left with these large amino acid chains up to 33 amino acid long. So that happens in all of us, right? And so, anticlimax. And so what happens is these large gluten molecules traverse the intestine, and that's happening all the time in all of us, and I'll get back to that. And so what happens is they come through into the lamina propria of the intestine, and maybe you've got gastroenteritis at the time, and the enzyme tissue transglutaminase that's ubiquitous will activate this. It will deamidate these gluten molecules, which then allow them to sit in the groove of this HLA molecule on antigen-presenting cells, and then it sets off this inflammatory cascade that releases cytokines that cause villus atrophy and inflammation and antibodies that we can measure in the blood. So these gluten peptides pass through the small intestine all the time, and they're absorbed into the bloodstream. You have a sandwich out there, and you can go and pee later on in the afternoon, and you're peeing out little gluten molecules. That's uniform. Therefore, a leaky gut is a normal phenomenon. That's not a disease. A lot of non-traditional medical practitioners are telling people they have leaky guts. Well, that's how we survive. That's how our immune system knows that a protein is foreign but allows us to tolerate it. And it's been well shown that if you give alcohol or NSAIDs or severe physical exercise, that leakiness will increase. This is a picture in the 30s of kids with celiac disease. Malabsorption syndrome had a 30% mortality. And it wasn't until like the late 30s in Amsterdam that Dr. Dickey listened to the mothers that said, oh, their kids got sicker when they ate bread. And he worked it out that it was the protein component of bread. And it was kind of confirmed in the Second World War because he was feeding these celiac kids tulip bulbs and mussels, and they were thriving. And then when the terrible conditions finished and wheat flour came back and they gave these kids wheat flour, they all got sick again. So we owe a lot to this guy, Dr. Dickey, who listened to the patients. But now when we look at all these children that are presenting with celiac disease, and this is a group of kids seen at Columbia, only 9% present with a malabsorption syndrome. The other major modes of presentation are recurrent abdominal pain, growth issues, which is either failure to thrive or short stature, and screening. The people that get screened, the kids that get screened, are relatives. Now increasingly, any child with an autoimmune condition probably should have those antibodies recognized. It's uniform for type 1 diabetics, but not for thyroid disease, but it probably should be. This is autoimmune liver disease and Down syndrome. All of these have about an 8% risk of having celiac disease. Amongst adults, the presentations are diarrhea. So diarrhea prompts the doctor to test for celiac disease. Just having an endoscopy, screening, and once again, it's the same groups. Metabolic bone disease. If your obstetrician, as in this country, for some strange reason, the primary care performer for women, it becomes an obstetrician, they may do a bone density, but they don't go looking why someone may have a reduced bone density. It could be due to celiac disease, anemia, and other. This is dermatitis pediformis. This is a dermatologist from Columbia who for 10 years had this itchy facial rash and started developing blisters. This is DH. And it wasn't until she got a little bit of alopecia, vitiligo, and some arthralgias that a very obsessive rheumatologist tested her celiac antibodies, and she had celiac disease. And this is DH. So it's the diagnosis is made by a biopsy taken about 1 millimeter from a blister, not biopsying a specific lesion. And this is a very gluten-sensitive condition. People will go and eat a gluten-free diet because gluten-free is not no gluten. It's just less than 20 parts per million, and they'll get a rash. And so we often give them medication before they go and eat dinner. And been very interested in these dental enamel defects. Our adult enamel is formed by age 7. So looking at an adolescent's or an adult's teeth is like a window on their health in childhood. And these are the dental enamel defects. They're developmental, therefore they're symmetrical. This white spot here is kind of here, like here and here. It's symmetrical. These are dental enamel defects. Here they're quite obvious. That's gluten-free chocolate cake there, but this here is dental enamel defects. And we did a study. We did a family screening study and had a dentist look at the kids' teeth, participants' teeth, and having a dental enamel defect predicts in a family that that child has celiac disease. And that can be the only presentation. Other tests, just mild abnormal liver chemistries, a low cholesterol. If someone's got a cholesterol of 110, people say, oh yeah, I know my cholesterol level. It's either high or good. And I say, well, what's good? I don't know, the doctor just said it's good. Sometimes it can be so good that you have celiac disease, because if you have a total cholesterol of 110, 120, you've got to ask, why is it so low? And it could actually be due to celiac disease. So there are a whole bunch of different blood test results. So typically, so we've been very interested in why this enormous underdiagnosis of celiac disease in this country compared to Australia or Italy or Ireland, where everyone says celiac disease is so common. It's 1% of the population, like it is here, but it just gets diagnosed more. So these are all the different steps to get diagnosed with celiac disease. The patient's got to go to the doctor. The doctor's got to think of it. He's got to order the right tests. He's got to be able to interpret the tests. If they're positive, refer for biopsy. The endoscopist has to take the right number of biopsies from the right places. The pathologist has to be able to interpret it. And then you get told you have celiac disease. And all of these steps, like men don't go to the doctor, even though we know it's 1%. I showed you earlier on, 1% of 20-year-old white men in Minnesota. The doctor doesn't think about it. We questioned hematologists about what percentage of them would consider making a diagnosis, testing for celiac disease with iron deficiency, because the recommendations are all patients with iron deficiency. You know, it was 8% of academic hematologists would consider testing for celiac disease. And then there's a spectrum of pathologies from mild, just inflammation, to mild villus atrophy to total villus atrophy. And we looked at a whole bunch of biopsies that patients brought in. Our pathologists, we had a very good degree of agreement if the original pathology report was performed at an academic university medical center compared to a community pathologist. So what are these blood tests that I had mentioned? The blood tests are this TTG antibody, the endomysial antibody, and then we have these synthetic deamidated, tissue transglutaminase deamidated gliadin peptide antibodies. And then we'll often measure total IgA, because selective IgA deficiency, which is a genetic condition, is associated with celiac disease and other autoimmunity. And you wouldn't be making a lot of these antibodies if you can't make those antibodies. So there are guidelines, and I'll see someone, and they say, I was told I had celiac disease. And it's very important that people are diagnosed according to guidelines, because the diagnosis will always be in doubt. You know, I have several patients that don't talk to their parents because they had them on a gluten-free diet from early childhood because they were considered to have celiac disease, and they didn't have it, and they hate their parents for having to. This is a very serious condition, very serious issue of putting kids on a gluten-free diet unnecessarily, because the diet becomes the big factor in the management of celiac disease, and it's the diet that affects the quality of life of individuals. And so to diagnose celiac disease, there are guidelines. And unless the guidelines are adhered to, the diagnosis could always be in doubt. In this country and in most countries, a biopsy is considered to be the gold standard of diagnosis. There are criteria in Europe for diagnosing a child without a biopsy, but they're very strict criteria. It's a TTG, IgA antibody level of greater than 10 times the upper level of normal once, but also repeated, because blood tests can get screwed up. It can be a different patient, or there may be some temporary phenomenon. These antibodies can go up with just an infection, actually. So it's very important that if someone's told they have celiac disease, that the diagnosis is based on guidelines. There's a lot of misconception about these HLA genes because you can do them commercially. Oh, now, like one of these commercial labs, one of the two big commercial labs is offering a direct-to-the-consumer tissue transglutaminase antibody, and you can get the gene test done just through 23andMe or other genetic testing companies. But so this is a picture. So this is the population of the United States. 40% of individuals in the United States have this HLA-DQ2 or DQ8, but all of those with celiac disease reside in this group. So if you're living out here and you don't have this, we really think you can't have celiac disease. Now, what's the big significance of celiac disease? The main significance to my mind is this increased mortality risk. It's significantly increased at whatever age you're diagnosed with celiac disease. Of course, if you get diagnosed at age 70 or 80, people are dying all the time. And so the risk of having the celiac disease as the cause of death is not high. But it was greatest in those diagnosed between ages 18 and 40. And this is, we've been working with the population database in Sweden, because there you can look at everyone, whereas you can't do that in this country. And the increased risk of death is from cardiovascular disease, and we'll talk about that, cancer, various cancers, and respiratory diseases. And we can address that by vaccines. So some of this is important. So the management is a gluten-free diet, and people get the information from different sources. The most important is from a registered dietitian who's knowledgeable in celiac disease. You know, there are pitfalls. Like we looked at contamination of food in restaurants. Gluten contamination occurs, this is when people buy gluten-free food. The contamination occurs mainly with the evening meal and not with breakfast or dinner, and it occurs with mainly pasta and pizza. So, but that's because the kitchen's getting very busy, I think, and you know, while they may care, they're not all that good. Communion wafers, and then there is the issue of medications. You know, when you take a pill, the bulk of a pill is a filler, and if it's cornstarch, that's fine, but it can be wheat starch. So it's actually, I didn't think it was all that important, but that you can get a significant amount of gluten, especially in over-the-counter products, dietary supplements, because they're not regulated. So there are two issues, and that's why it's so important to see a dietitian. One, knowing what to avoid, and that's pretty easy because you can read labels, etc. But the most difficult part is knowing what to eat, because people mainly eat like rice-based products, and rice is not a very nutritious grain. And you've got to remember that a gluten-free diet is not zero gluten. It's less than 20 parts per million. So clinically, people can improve very rapidly. Symptoms improve, the antibodies go down. So within a year, they're usually negative. And within 2 to 3 years, the biopsy can be normal. We see a lot of people with persistent symptoms, and they may have bacterial overgrowth, lactose or fructose intolerance. They might have inflammatory bowel disease or microscopic colitis. So the main people that we see up at Columbia The 5 gastroenterologists that are seeing all the patients with celiac disease are people that have persistent symptoms. But there's a development. We're currently doing studies with 4 different drugs looking for a medication, because I think it's been very unfair that people with celiac disease have not had the offer to take a medication. And if you have celiac disease, you've got to think about what you're going to eat all the time. You know, if you have high cholesterol, you just take a pill and then increase the dose and go and eat whatever you like anyway. If you have cancer or inflammatory bowel disease, you can get pills, chemotherapy, biological agents, and feel totally normal. But people with celiac disease are thinking about this all the time. And in this study, at least 75% of people were very or mainly interested in there being a medication. And their meds vary, like there are enzymes to digest these non-digestible products. The drug that was supposed to stop the gliadin molecules coming across didn't work. The vaccine that came out of Australia didn't work. Biological agents will definitely work. So there's lots ahead for the development of therapies. Now, what about this gluten? So, you know, it was about 15 years ago that gluten started to become like a terrible thing, right? And this new diet villain in Newsweek, I can't quite see the date here. Oh, in 2008. So we've been very interested, and all the celiac experts around the world were wondering, like, what's going on? Why are we suddenly seeing all these people who claim gluten sensitivity? And it became propagated. There are these pseudo-scientific books like Grain Brain and Wheat Belly that became bestsellers. And this becomes the food, the fodder for late night comedy. I have wonderful little clips from late night shows. I don't know what gluten-free is. I don't know what it means, but it seems to be the trend. Djokovic, anyone read his book? He was diagnosed with celiac disease or gluten sensitivity by a doctor. The doctor held white bread above his abdomen, and every time there was white bread there, his musculature was much weaker. So that's how he got diagnosed with gluten sensitivity, that he attributes his wonderful success to changing his diet. You know, gluten-free singles, there's evidence that gluten-free singles have more sex, actually. And then all these personalities, you can look like this if you go gluten-free. So there's tremendous pressure on people to change their diet. So we were very interested in this. And we started working with Julia Belluz at Vox.com. And we were looking, so we looked at the most, or she looked at the most Googled diets based in the major cities around the country. And here you can see in 2006, the different diets, like the light blue is Atkins, the darker blue is low calorie, low carb is the light green, veganism is the orange, organic food, right? And in 2006, there were only this gluten-free, right? So this is like Austin, Texas. This is Colorado, probably. I don't know where that is. And so this is Google Trends. And you know that you can predict where the flu is based on Google Trends prior to the CDC knowing. So Julia looked at this, and look what happened with the most Googled diets. So you can see that diets are trendy, and the gluten-free diet became so trendy. And here it's interesting that down around Texas here, the paleo diet was starting. So, but still over here in California, they're a little bit behind with gluten-free. So you can see that diets are trendy, and looking at these Google Google Trends. And we actually did a study with that data and showed that the increase rate was related to socioeconomic factors, higher socioeconomic, and being white, and not being in neighborhoods that had high rates of diabetes or food poverty. So it's purely a socioeconomic thing. Now, and we don't think that a gluten-free diet is a very healthy diet. Like, it is not uncommon for us to see a patient coming in with celiac disease on a strict gluten-free diet who's B vitamin deficient, low in folate, because we know that mainly it's wheat flour that they're eating and there's no fortification. I've seen someone with very severe neurological deficits due to vitamin B6 deficiency because of a gluten-free diet. Gluten-free diet is not a healthy diet. It's low in fiber, iron, and B vitamins. The gluten-free products are like any product. If they take a flavorsome thing out, they'll add the other stuff back. So it may have increased salt, fat, sugar, rather than having gluten. I can't eat all these little bars that they leave in the office that are gluten-free because they've got so much oil in them that it aggravates the reflux. There's increased heavy metals. That NHANES data of all those people on a gluten-free diet had increased heavy metals compared to those people who are not on a gluten-free diet. And while there wasn't that much elevation in the toxic range, they were high above the normal range. And I think that could be very worrisome for kids, right, on a gluten-free diet. And we've done at least 2 studies with the people in the School of Public Health in Boston, looking at the nurses study, looking at over 100,000 normal people, developing a gluten index, right? And so you can classify people of eating a lot of gluten or very little gluten, and they're normal. They don't have celiac disease. There was increased risk of type 2 diabetes and heart disease in people in the lowest gluten intake. And we know that people with celiac disease have increased risk of heart disease. And we think that it's 2 dual phenomena. One, chronic inflammation, as people with any autoimmune disease have increased risk of heart disease. And the other is it's a gluten-free diet, which is not a healthy diet. So that's why it's so important for people. I've had celiac disease. People say, I've had celiac disease for 25 years. I know all about it. I don't want to see your dietitian, even though you're not going to charge us. But in fact, they're the people who should be seeing the dietitian to make sure that their diet is a healthy and varied diet. So, diets are trendy, and they're considered easy fix, right? Wouldn't it be wonderful if, like, you lost your job or you're feeling depressed and, you change your diet and things get better, because it's the one thing we can do. We can really control what we eat, whereas, you can't control, the rest of your life often. And the gluten-free diet has got medical legitimacy because it cures celiac disease, right? So all those other diets in the Google thing, low carb, organic food, South Beach diet, etc., they don't have real medical legitimacy. And what's very concerning is gluten restriction often leads to more food restriction. Like, it's not uncommon to see people like, I'm avoiding gluten, soy. There's something in the diet called nightshades. I'm avoiding nightshades. Like, people will select specific foods that they attribute symptoms to, and we see people who have this orthorexia or this avoidance restrictive food intake disorder, in which people are avoiding all these products because of something in the product affecting them. And we actually teach people maladaptive eating behaviors. Someone with celiac disease, like, they think about food all the time, they take their own food somewhere, they talk about it, etc. And these are maladaptive eating disorders that are actually forerunners of eating disorders that are present, increased in people with celiac disease. So, this gluten-free diet is not a healthy diet, and people with celiac disease really need the help of a very experienced dietitian. So thank you very much.